Chapter 13, Video 1. Today we're going to talk about how to interpret a 12-lead EKG. So we're going to go through those steps and everything. It's kind of a recap of everything that we've been over. With the 12-lead EKG, this is considered a diagnostic test, and the primary purpose of the 12-lead EKG is to identify the presence of a myocardial infarction or an MI or ischemia. And remember, this word ischemia means loss of oxygen. That tissue is dying. It's not getting oxygen. It's losing oxygen. It's also useful in identifying arrhythmias and other conditions like electrolyte imbalances or drug toxicities. Some drug toxicities like digitalis toxicity, this would cause your heart rate to fall too low. If you had an electrolyte problem, like if you had a potassium problem, that could affect your heart. So that is one thing that we're looking at when we're talking about electrolyte imbalances. With the EKG, we're going to put the patient in what is known as supine position, S-U-P-I-N-E. Just understanding some medical terminology. Supine means laying flat on your back. So we're going to put that patient in supine position, laying flat on their back, for this EKG. Moving forward, there is 6 steps to 12-lead EKG interpretation. One, we're going to interpret the basics, okay? We're going to identify the rhythm and we're going to calculate the heart rates at intervals such as the PR interval, the QRS, and the QT. So we're going to count that heart rate, and then we're going to look at these intervals, and then we're going to say, is this normal or is it abnormal? Is this heart rate within range? Is this interval long or is it short? Or do they fall within normal limits? So remember, we have to know our normals when we're asking ourselves these questions. And remember, with a prolonged PR interval, this can imply that there is a block in the conduction pathway anywhere between the atria and the ventricles. A shortened PR interval can signal a change in the heart's pacemaker. When we're looking at the QRS interval, a prolonged QRS interval can imply a ventricle rhythm problem. A prolonged QRS can imply that something's going on in that ventricle. If we have a block of the bundle branches or electrolyte imbalances, this could show as well in those QRS intervals. A prolonged QT intervals, they're herald for lethal arrhythmias. So if we have a prolonged QT, then we need to be thinking about, okay, what's going on in those ventricles, because it can lead to a lethal arrhythmia and be deadly. One of the things that we're going to do as well is we're going to determine the axis quadrant. And remember, this axis is a method of determining the mean direction of the current flow in the heart. And we went over that earlier in the semester. So look back at your notes and look back at those lectures. And if you have any questions about that, please let me know. We need to check for bundle branch blocks and hemiblocks. And then we need to check for ventricular hypertrophy. When we're checking for ventricular hypertrophy, we're going to use V1 and V5 and V6 to check the QRS complexes for signs of ventricular hypertrophy. And what we will see in those leads is an increased R wave, an elevated R wave, okay? So using V1, V5, and V6 to check the QRS complexes, and then we're going to determine these miscellaneous effects, okay? So we're going to be able to use this criteria to determine what is going on there. So as we move forward, this is our normal EKG deflections. So make sure that you know your deflections. And again, we went over this earlier, but make sure that you know what you're supposed to see in lead 1, lead 2, and lead 3. So with lead 1, it's positive. Lead 2 is positive. Lead 3 is positive. AVR is a negative. AVL is positive. AVF is positive. V1 is negative. V2 is negative. V3, we have that isoelectric. It goes both ways. Again in V4, and then V5 is positive, and V6 is positive. And so these arrows indicate the correct deflection of what you're supposed to see. Lead morphology practice. We need to determine if the following QRS morphologies are normal. If not, we're going to tell what is abnormal. By analyzing the morphology of each lead, we can get an idea of where there is pathology on the EKG, so where there's a problem. So looking at this, we need to go back to that previous slide, and we need to say, okay, is 1 correct? 1 is, it's positive. 2 is positive. 3 is positive. AVR is negative. AVL is positive. AVF is positive. So these look normal. Everything down through here looks normal. So we have a normal morphology. So we look at these directions and we can tell on this particular slide, the answer would be normal morphology. So moving forward, let's look at lead 2, practice 2. All right, let's compare. Let's go back to our previous. So lead 1, that's normal. Lead 2, lead 2 is supposed to be positive. Lead 3 is supposed to be positive. Lead AVR, when we're looking at AVR, it's negative. Okay, so we're good there. AVL is positive. AVF is positive, but it's negative here. So when we look at AVF, it's supposed to be positive. Then we look at V1 and V2. These look normal. V3, V4. All right, V4 is isoelectric. V3 is supposed to be going the both ways. So we got something going on here. V5 and V6 are both positive. So right here we see that we have abnormal morphology. Lead 1 is normal. Leads 2 and 3 are negative, and they should be a positive deflection. AVR and AVL are both okay. AVF is negative, and it should be positive. And the precordial leads, these look okay. So this is abnormal morphology with those changes. Stepping it further, lead 1 here is negative, and it should be positive. Leads 2 and 3 are okay. AVR is positive, and it should always be negative. AVL is negative, and it should always be positive. AVF is okay. V1 is positive, but it should be negative. V2 is okay. V3 is positive, but it should be isoelectric. V4 is isoelectric, and it should be more positive. V5 and V6 is negative when they should be positive. So here we have abnormal morphology. Moving forward to the next one. Lead 1 is positive, as it should be. Lead 2 and 3 is negative, but they should be positive. AVR and AVL are okay. AVF is negative, but it should be positive. The precordial leads here are all positive, and this is completely abnormal. So again, here we have abnormal morphology. That is it with this, with chapter 13, video 1. I will return to resume through chapter 13 in a later video.